Jetzt gehen wir nach Dänemark. Denmark, a role model for the Swiss healthcare system. Das wird ein interessanter Ritt, der uns ein bisschen durchschütteln soll. Wir können von Dänemark lernen, wir können Unterschiede sehen, wir können Dinge mitnehmen, wir können auch sagen, nein, das interessiert uns nicht. Ich begrüße ganz herzlich Jakob Kjelberg. Er ist Chef des VIVE, Denmarks Center for Social Science Research, und der Claim dieses VIVE ist provides knowledge for development of the welfare state and the public sector. Ich glaube, that's something we would like to have in Switzerland as well. And then he is followed by Kjeld, Møller Pedersen. He's an economist at the University of Southern Denmark, and he served for years, I must say, as an expert in many committees for the Danish government, for different governments, whoever was in charge of it. Very interesting, and welcome to Switzerland. I'm looking forward to your speeches. Thank you very much.
And I would like to say thank you for the invitation and giving the opportunity to learn from the Swiss system and then share the experiences from the Danish healthcare system. And we've been through a number of recent proposals, and maybe we want to, I don't know if we can change the slides. No. To say a little bit about the Danish healthcare system, and there are some differences between the Danish system and the Swiss healthcare system that makes it. You have to understand the background for how we can make reforms and why it might be slightly more difficult in a Swiss healthcare system. Denmark is basically a universal tax-funded system. Almost all of the funding comes from the government. We have co-payment, we have voluntary health insurance. Lots of people have actually insurance in Denmark, but it only covers about 3 to 5% of the total healthcare expenses. Then we have co-payment, but most is financed by the public sector. And the hospitals are, with a few exceptions, publicly owned and publicly managed. GPs, practicing specialists, office-based specialists, they are private entrepreneurs, but almost entirely funded by the public sector. So it gives a purchasing power from the public sector that is different, and you have to understand that is different in the different systems. If we go a little bit about the history of the Danish healthcare system, until the 70s, we actually were a high-spending country. Now we spend about 10% of GDP on average in OECD, but before that we were, together with the US, very high-spending. And then we have all kind of economic crisis, and we stopped investing in our healthcare system. We were still convinced that we had the world's best healthcare system with the highest quality in the world. Lack of data is a blessing. Then we got quality data, and we figured out that we actually had a very slow adaptation of new technologies. We were lacking in cancer survival especially, and other high-cost interventions. We had the impression that we actually had an excellent system, but when we saw the data, it was not clear that it actually was so. So we had a backdrop. For the current reform is a major structural reform in 2007, where we changed the number of counties, basically your cantons, from 14 to 5, because we want to say that if we want a specialized healthcare service, it cannot be sustained with 14 counties. We could only have 5 counties. We also reduced the number of municipalities from 271 to 98 so they could take care of the responsibilities within healthcare, a decent specialized matter. And we also reduced the number of hospitals with acute intake from 45 to 21. So massive implementation of the specialization of the healthcare system. Kjeld will say a lot about how we actually went about doing that. But that is a background for the current reform, because even though we had a massive reform only 20 years ago, or less than 20 years ago, what we forgot in that reform was how to deal with the patient outside the hospital system. So we went very hospital heavy, and we didn't really develop the GP sector and the office-based specialist, and also looking into the demographic change that we are also facing with a number of elderly, that we cannot just take them all into hospital. We need to deal with them in the municipalities, in the elderly care, to bind the healthcare system tighter together. And that's where I come into the picture, because we had a new majority government, and they could see we had problems in the healthcare system, but they couldn't see the solution. So they asked 8 experts, independent experts with no organizational ties, to say, could you think out of the box and design us a new healthcare system so we can be inspired and actually do some of it? Because these challenges are complex. We cannot deal with them in the political system one by one. We need a full reform. So we had a year to draft up a reform of the healthcare system. And we went through the first steps is to say, well, how is the Danish healthcare system problematic compared to other countries? And then we look at how much we spend in hospital care, we are different from many other countries. Only Brazil and Turkey spend as much within the hospitals as we do, and too little outside the hospitals. So we had to change the balance between the hospitals and the rest of the healthcare system. That was one of the keys. We also see where we employ the doctors. We actually got many more doctors in our healthcare system. Since 2000, we have doubled the number of doctors working in the hospitals, but we have very slow progress outside the hospitals. So we need to shift the balance between working within the hospital and outside the hospital. And some of the problems we have when people working outside the hospital in the GP sector, we had a number saying 1,600 patients. That's for one GP. But the problem is that over the last 25 years, we have segregated our population in Denmark and many other countries because people move to the big cities. The wealth of people move to the big cities. The rent is high there, so people are segregated who cannot pay the rent to outskirts part of the country. So a patient is not a patient when we have 1,600 young, healthy students. It's much less of a workload than if you have 1,600 elderly with multimorbidity. So what we saw is that it's very difficult to attract staff and GPs to the outskirts of the country because it's much harder work and they have to live places where they don't really want to live. So we also have to make it more advantageous and better work-life balance in different parts of the country. So we have to differentiate the number of patients you need to take care of where you live in the country based on the social demographic factors and the age and the morbidity and all that. So that's one of the things we're looking at. And then we had some opportunities and also some threats. But we look in the projection of the supply of labor. We are in Denmark educating lots and lots of doctors. We are actually, if we look at the demographic change, we need about 2,500 more doctors within the next 25 years. But we actually educate 10,000 on top of that. So we have an opportunity to make the labor market different for the doctors, saying that if we stop hiring doctors in the big cities, then they might actually move to some of the underserved areas of the population. But to do that, you need to have some structural changes and have some power to say that you don't want to employ the citizen there. We have a massive problem, especially with assistant nurses, and therefore we also have to tie up the elderly care with the hospital care so we use the resources better. So that was basis of the recommendation from the Health Structure Committee, that we basically said we have to think, and this is in Danish, I'm sorry, but we have to think about healthcare not as in 3 sectors, but for when we look at the elderly, the plus ages, people is especially, there is no patient, there is no my patient. What we can see is they are overlapping for the resource use, both in the municipality, the elderly care, the GP sector, and the hospital. We have to think and integrate the healthcare system in better ways. We came up in the Healthcare Structure Committee with 3 proposals, 2 very ambitious ones where we basically merged the budget for all of the sectors and changing the entire landscape of the society and the administrative society in Denmark. The politicians were not that keen on that, but we had a third option as well. They went with where we said we have the state and we reduced the number of regions from 5 to 4. That was their own suggestion, really. And then we introduced 17 health councils that have the responsibility to develop the healthcare system outside the hospital system. And to do that, a lot of funds are now earmarked. All the growth in the healthcare sector, 75% of the growth have to go to the health councils. So basically we are starving the hospital sector to grow the outpatient care system where we need more capacity, especially with the demographic changes. But within the reform, that was what the politicians looked at. But to make that happen, there's lots and lots of reforms within the reform. To be able to do that, we have to make a reform of how we manage the GP sector and who control that. And a complete change there, where lots of the authority for the individual GP to settle down where they want to, is taken away. The veto power is taken away. And to do that, you have to bribe them, of course, so lots of money will go into the GP sector. So we'll increase the number of GPs from 3,500 in Denmark to 5,000 within 10 to 15 years. We focus on education, lots of money into research. We have stopped from January 1st the right to settle down as a GP in areas where there's good provision. So if you want to be a GP now, for the coming year, you can only settle down in areas of the country where we are undersupplied. We're looking at the list side right now. I'm in the commission where we have to figure out what is the right list size for population-based area. Then we have put a cap on hospital staff. Specialists within working in hospitals will be individually calculated for all hospitals, and they are not allowed to employ more staff than the number of the cap is indicated. Basically to not force, but incentivize doctors to go to areas where we need doctors instead in the Copenhagen area and the bigger cities where we are oversupplied. Then we have the cap on the spending, where 75% of all new money, demographic-based money, will go to the health council, who cannot use the money in the hospital sector. So we build up what is not focused on in the political system, always highly specialized care, cancer care is in the focus, but we build some boundaries so we actually spend the money where we need it. Then we have the health structural reform, the task reallocation. We take the intermediate beds from the municipalities to the new health councils, also the funding. We also have some of the nurses who previously worked in municipalities. They will move to the health councils. So we tie better together the inpatient care and the outpatient care and the elderly care. Then there's a reform of the digitalization. We have actually good digital healthcare in Denmark, but what is happening now is that we take the responsibility for the digital infrastructure from the regions to the state, because we think too many times we invent the wheel in individual regions. We need to even go faster with the digitalization process. So a new area for the National Board of Health will be and will be the digitalization and forcing that to go faster. There are also new patient rights. We have cancer rights packages, but now for chronic disease will be in focus because we'll have so many more chronic diseases with the elderly population. So they will get packages. And then we also have lots of other changes. I can't go through it all. It's a 300-page reform of the Danish healthcare system, but we also have an integration of the somatic care, because psychiatry and somatic care, well, they have kind of grown independently, but we can see there's a lot of interactions between psychiatry and somatic care that need to be integrated and tied better together. So they will be integrated. So a massive reform where it actually what needed to be done within the framework of the politicians who said we have to do something to meet the challenges, give the experts the freedom to say how do we think it should be. And what is really interesting is that everything we have suggested basically has been passed through Parliament, or including spelling mistakes, really. So now it's all about implementation, so it's easy to draft a white paper, but the interesting thing is that we actually have a tendency in the Danish healthcare system to implement it. And I think Professor Kjeld Pedersen will tell us about how we've implemented some of the earlier reforms that we actually managed to change our healthcare system dramatically. We used to have a very good healthcare system, we thought so, then we got data, then we had poor healthcare system, and we track the healthcare data now, and we are actually number at least top 5 in the world for cancer survival now. We used to be about in the bottom, like Eastern Europe. So monitoring data, structural reform actually is possible to improve the healthcare system. Give the word to you.
Well, first of all, thank you for inviting me. I have divided my presentation into two, one on e-health and then on hospital planning. And I hope to get through all of it. And if we look at the situation, actually, as Jakob indicated, we are actually world leading in e-government, set at these United Nations. And if you look over here, you will also see that we are able to report a portal for patient access to that, and that's available to everybody. So in that sense, we are doing fairly well. Now, if we have a quick status, first of all hospital patient records are fully digitized. It's not a 1% as here. And also, if we take the patient records from the DPs and office-based specialists, are also fully digitized. And if we move on, then we have basically two, if you wish, national IT system for the hospitals, and that had come down, as you can see, from 27 in 2007 to 2 today. And in a similar vein, if you look at the general practitioners, we had about 16 systems around the turn of the millennium, and now that has brought down to 4 systems. All these systems are provided by private companies, incidentally. So it's not provided by the public sector as such. Then we can see what are the advantages of having a fully digitized system. And we take full advantage of that in what is called Gesundheit.dk and an app called My Health. And that is basically, as you can see, an official portal for the public Danish healthcare system, and enable citizens and health professionals to find relevant information on treatment patterns and a lot of information. And actually what is important, that close to 100% of Danes do know about Gesundheit, and actually this year actually from January, September 24, we had 44 million people accessing that application. And if we look at it from the health professionals' point of view, 1.7 million hospitals access that, essentially that is hospital doctors, and they could see what has been the treatment path so far. And in a similar vein, 1.3 general practitioners also accessed that system. And how I wouldn't say how did that come about, but anyway, there are two important aspects. We have a national digitalization program or strategy which has been decided by central government, the regions, and the municipalities. So it is a kind of a collaborative effect or effort, and that has taken place basically since the turn of the millennium. So that's what we are seeing the interest or the effect of. And similarly, and I come to that a little bit earlier, but actually it's very important that all Danes have a unique ID number. And that means using that unique ID number, you can merge information from various sources, and that is used to full advantage. So if we look at the Gesundheit.dk and say, what are the data sources? And as you can see here, we have the patient electronic records, we have lab responses, biochemistry, pathology, etc., X-ray descriptions, everything is in there. And obviously linking that takes a unique ID, which is used throughout. So we are really merging information in that way. And then who are using it? General practitioners, hospitals, municipalities, and citizens. So actually everybody is using it. And in a sense, and I'm not overdoing it, but it's really in real time. For instance, if I've been to see my general practitioner, the next day at least, I can go in and see what did my blood test show, etc., And in a lot of cases, it's even faster than that. Then we also have an application for general practice called My Doctor, and it's available where you download your apps. And about, as you can see out to the right, 2.5 million active users actually, and that has been developed in cooperation with the Association of GPs and the Ministry of Health. So as what we also see in a lot of cases, it's a collaborative effort that is taking place. And if you look at that, for instance, you have access to a video consultation via your app. You have name and address of your GP on the list of whom you are, and then obviously you can see what are messages from the GP, appointments, medical records, including medication and prescription overview. It's available, and it's available basically online on time. That was basically a very quick walkthrough of the e-health, and in a sense it is working well. And actually what is also important is that data privacy obviously is a priority. So actually the real important thing is that it is simply you need population to have faith that data privacy is protected. And in many meanings of the word, actually you have to be fairly hysterical about that. You have to protect it, because if it's not protected, then both health professionals and citizens will lose faith in the data. And that has succeeded so far. And on top of that, it's usually said that Danes are actually a very trusting people. And they trust the authorities. They actually also occasionally trust politicians. So actually that's important. So actually that's why we have moved so far with e-health. Then the minister raised the question of, are there savings by digitalization? I have to say yes. And then when you say, can you prove that? Have you long reports? No, we don't have that. But obviously, in a sense, it's so obvious. You can save administration cost, you can save time when you access treatment, etc., etc. So in that sense, you can say it is a belief, but actually, I have a very strong belief that it is saving money. We have a fully digitized system. It can be better. And actually, as Jakob was outlining, we'll change the organization of that system in the coming years. Gradually, this is not just snapping your fingers to do that, but still it is very important. And I think actually it's a prerequisite for a well-functioning healthcare system, that is that you have a digital infrastructure and you use that to full advantage. And I think actually it is used to full advantage. I think it can be used even further. But also you have to realize that also it's very useful for research purposes, where you can link different databases through the unique national identifier, and then we have incredible possibilities in research. So actually that's an added, if you wish, benefit. And again, when you do that, you have to be careful to protect data privacy. But as I indicated, I think we are doing well in that regard. We have occasional slips on that, but still it is important. We can track who access data. So actually you cannot just have anybody accessing my hospital data. That has to be relevant. And if it's not relevant, if you're just curious to see how my health's doing, then basically you'll be fired. And that's doing with, I think, great consequence. Now, turning to hospital investment and planning. We go back to 2007, and Jakob already talked about that, but just to make sure that we have the point of departure. In 2007, we reduced the number of regions, or counties as we call them, to 5 regions. And obviously that required a consideration or reconsideration of hospital structure, because what is optimal for a county is not necessarily optimal for a region. I'm not saying cantons, but just to give you a thinking of that thing. So actually that was simply needed. Furthermore, we also had a principle that the size of the counties originally and the size of the regions should have a sufficient population base to support a fairly specialized hospital structure. So that's also an important thing. In a sense, the geographical division of the country was basically dictated by considerations of hospital structure. So we are back now in 2007, and now we will look at how we restructured the hospital structure. That was a process that has gone from 2008 until actually 2026. So just think about it. It's not just snapping your fingers. It's a long-term project. And actually, we will be completing it with the last university hospital in a couple of years. First of all, you need a fairly strong hand when you do that. So we have the National Health Authority, which is providing the professional basis for what we are doing. And they published a planning guide in 2007. And basically, that was saying to the regions, this is how it's going to be. So you could say that dictated it, but actually that is fairly true. And what took place when we did that? First of all, we introduced a new model for the organization of emergency admissions as of 24 hours a day. And the new model was basically that at each hospital, in principle, you had only one entrance to the emergency admission. So if you come in with a broken leg or have a heart attack, you will go into the same acute admission section. You will not go directly to orthopedic department or to a department for heart diseases. We have one common thing, and the only exception is a few exceptions from that. And then the beds allocated to that new facility was basically taken from the more specialized department, a zero sum and a little bit less than that actually. And then the idea was that ideally when you are admitted in an emergency case, you will be seen by a specialist. It used to be quite often that you were seen by the youngest hospital doctor or even worse, medical students at some of the small hospitals. And patients were expected to stay less than 48 hours within that special emergency department. And as you can see at the bottom at the slide, actually at least 70% are discharged within 24 hours. That's because a lot of elderly people, dehydrated, etc., can be discharged that fast. And then we put a lot of money into it. So actually government allocated about 5 billion Swiss franc for that. We did not have to go through a referendum. It was just government said that and used that for new hospitals and renovated hospitals. And if we look at how it worked, then we have every year, we have a pact, if you wish, an annual budget agreement between central government and the 5 regions. And in there, they decide a lot of things, and they want to establish expert panel. As you see from Jakob, we have a kind of a love for expert advice in that thing. And then government and the regions together decided to establish a 5-person expert panel, 3 Danes and 2 Scandinavians. Scandinavians to get information and inspiration from other countries. And we had Norway and Sweden, and that makes it easy because all of them can read at least Danish. So that's the one, and 3 Danes, and I was one of them. And then already in August, so June 27, it was decided, and in August, same year, basically the 5 billion Swiss franc was approved. So that's fairly quick, and amazingly quick actually, I should say. And then the expert panel went to work. We wrote 2 small papers on that. In the first one, we distributed about 3.1 billion Swiss franc, and then a couple of years later, we distributed the remaining. And what was amazing about this, Dirk indicated something about what happened to the white paper from the expert commission, but here actually all our recommendations were followed. And you could say that was that because we were clever? Unfortunately not, but simply it was considered that it's so difficult, it's really a puzzle to develop a hospital structure. And actually politicians realized that if they started fiddling with that, probably they brought disorganization into the picture. So they accepted everything, and like Jakob said, spelling errors, everything was accepted. And then if you look at the consultation process, the chairman of the panel, I don't know what the order was, consulted the Prime Minister, consulted the Finance Minister, consulted the Health Minister. And that was basically just to say, this is what we have arrived at, and do you have any comments? And at least he came back and never told us they had comments. So they accepted it. I'm not saying this is rule of experts, but actually some issues are so complicated that probably you need, to a certain extent, to be willing to follow expert advice. And hopefully we're not always right, but we're not always wrong either. So that's one thing. And then the red dots, those are the red dots, that's where we get the new acute hospitals and distributed the money. And actually, if you look at the map, you will see fairly even distribution across the country, and the regions decided on the location of these new hospitals. We allocated quite a bit of money to university hospitals, because actually it was the idea that in each region you needed a flagship hospital, and that would be some of the new or almost new university hospitals. And then we had local hospitals. We have money for psychiatric hospitals, was also part of it. So there was a kind of, I wouldn't say it's an even distribution. We never considered that, but still we managed both to get for somatic and for psychiatric hospitals. These are some of the pictures of the hospitals, university hospitals, and regular hospitals. Just to give you the most recent hospital that was developed was a greenfield hospital in the western part of Denmark. And as you can see, with about 640 beds, about 4,000 employees. And actually what is also important, they had to stay within budget. The money allocated to the development projects, they simply had to stay within budgets. And if not, then you had to reduce the projects. At least that was how it's used. I think it's actually loosened a little bit recently. And the result, first of all, we had a dramatic decrease in hospitals with acute. Maybe the figure to the left is a little bit exaggerated, but still it's from an official report. And what also was important, that we closed quite a few hospitals. 17 were closed, and some were changed in the assignment, not from acute admission, but say to specialized cancer hospitals or specialized hospitals for certain types of surgery. And you should not look at this one, but actually this accounts about 30 smaller hospitals that were also closed in the process. So actually it was quite radical. And then also as part of the centralization of hospitals, it was a prerequisite that we should also address how to develop pre-hospital services. If you get longer to hospitals, you need better ambulance services, helicopter services, etc., etc. So that was expanded correspondingly. And then just linking up to Jakob, when we did this, we did not think about the general practice and the municipalities. It was neglected. It was not part of the mandate, and this is what has been rectified in the subsequent reform. Thank you.